Hello, Health Psych students. We are now on part 2 of pain. In the first part of this lecture, this online lecture, we talked more about the differences between acute and chronic pain and why it's there, the whole evolutionary nature of chronic pain. And then my plan for now for part 2 is to focus on treatment for chronic pain. And then at the very end, which we were gonna spend a class time paying attention to, is a wonderful documentary about Dr. JonKabat Zen from Bill Moyers. That's going to feature, you're going to be able to watch some of these pain treatment interventions live in that documentary. So let's talk about cognitive behavioral therapy, CBT, for chronic pain. Here in CBT, we're changing the experience of pain by changing the thinking and the behaviors that surround chronic pain. And there are strategies like distraction, which works really well for a lot of individuals for chronic pain. So as an example, imagine that you have to go in for some kind of dental treatment or get a cavity filled or that type of thing. The local pediatric dentist that my boys went to when they were growing up, she was fantastic with this kind of stuff. They would lay there in the chair, and instead of looking at the bright light, they would get sunglasses. They would be allowed to have earphones if they wanted to listen to music, and they would even be allowed to, while she's working on them, play a little handheld video game, which was just brilliant distraction for a child who's undergoing a really uncomfortable position. If you have to ever do anything like that, if you've got the possibility of either listening to a meditation or listening to music that's enjoyable while you're having some kind of procedure like that done, it's a great way of distracting. In Lamaze, when women do prepared childbirth, they are oftentimes learning different types of breathing for different stages of labor, but then oftentimes will have a particular focal point of something that they are focusing on as they're coping with the discomfort that can happen in labor. I still remember my older son, Christian, when I was in labor, I had his little blue outfit hanging up on a dresser, and I could see it. And anytime I would doing the breathing when it wasn't working well, I would just focus on that cute little blue onesie, and just like, oh, my baby's going to be in that pretty soon. So distraction works really well. Relaxation, all kinds of different relaxation or meditations, diaphragmatic breathing, all of that is really good, because if you're focusing on that stuff, you're not necessarily focusing so much on the nociception and that pain perception, but then also being able to relax the body oftentimes eases a lot of pain. So as an example, a woman in labor, again, if every time she has a contraction, which would be happening down in her uterus and her lower abdomen, if she tenses up her whole body, then her body is going to be under a lot of distress. If on the other hand, she's doing her breathing and she's totally relaxed everywhere, then her uterus has the ability to use all of its body's energy to make those contractions to help prepare to get that baby out of there. Exercise is a wonderful way of keeping the body healthy. You physical therapists, we just talked about that, keeping the body strong, keeping it flexible, keeping it capable of doing whatever movement you're asking of your body. Exercise keeps blood flow going, which is really good. Even exercise oxygenates the brain. But keeping the muscles well fed with blood and oxygen and nutrients from exercise is going to be valuable. And so that's a strong component. Other program components, we usually start when we're working with chronic pain patients by assessing the kind of pain that they experience. And it's really valuable for chronic pain patients to hear from healthcare providers like health psychologists that their pain is believed, that there's not anybody saying there's nothing else we could do, or this must be in your head, or you must be doing it for secondary gain. And we will oftentimes have them do self-monitoring. Nowadays, again, there are apps for phones. You could have somebody download an app and different times of the day record the type quality of the pain, How high is it, like on a scale of 1 to 10? What were they doing? Was there anything that they did or didn't do that triggered it? Their emotional experience around the pain, and even getting at those automatic thoughts so that we can start the cognitive therapy piece to it of what's going on. In the old days, we had these paper and pencil diaries that people used, and we would still use them maybe with an older generation who might not feel as comfortable using an app on their phone. But lots and lots of valuable information comes from that self-monitoring, because we start looking for patterns. When is it just totally out of random and out of somebody's control, versus when is it happening and it's specifically situational? So an example would be, let's say I have a client who wants to vacuum her entire home, but because of her chronic pain, after she's done enough self-monitoring, she realizes she can vacuum or mop her floor for 10 minutes. But when she pushes it and tries to do the whole house and tries to do 30 minutes worth of vacuuming and mopping, she either pays for it then, she pays for it that evening with an increased level of pain. And then some of the pain patients, this is where it really gets tricky, and the self-monitoring is really valuable. Some patients pay a day later. It's like, you know, they're feeling good as opposed to all the days they're feeling bad. They push it, push it, push it. They clean their whole house. They go to work. They do their yard work. They do everything. And they're fine that evening. And then they wake up the next day and they are in trouble and can't get out of bed, that kind of thing. We do a lot of educating people. So a lot of the stuff that I kind of lined out for you in part 1, explaining pain and why we have pain. We've got this mentality, and this is a little bit attributed in the United States to the pharmaceutical companies that make pain meds, but we've got this almost this attitude that we shouldn't have to experience any emotional pain. We shouldn't have to experience any, physical pain in our body, this idea that we don't deserve this. And I find it fascinating, even if you look, and the ACT people have kind of explicitly spelled this out. If you look at the book of Genesis and what happened to Adam and Eve in that story, it is regardless of what you believe religiously, it is a story trying to explain the origins of pain and suffering in the human experience. And I like it as a story in that regards, because it helps me to realize human beings have been wrestling with this, at least through recorded history when they wrote that down. Because we've all experienced pain and suffering and disability and that type of thing. And if we have this idea that we shouldn't have any of that, well, good luck, because that's not life for most of us. And so the educational piece to it, oftentimes setting out goal setting for a patient. There's a book that I use. It is written by Margaret Caudill, and Margaret Caudill is both a medical doctor, MD, and a PhD, a clinical health psychologist. So she is a very educated scientist and practitioner. And she's written a book that it can be used as self-help, or it can be used where a therapist is using the book with a chronic pain patient. But the book is called, this is important, Managing Pain Before It Manages You. And it is in the goal setting and the expectations. Most pain patients, chronic pain patients, and this makes perfect sense to me, they want it to go away. They want to get back to their old lives. They want the pain to go away. They want life to be, non-suffering, emotion, all that kind of stuff. They want it to be pain-free. And that's just not realistic for a lot of these chronic pain patients, because they've got chronic other conditions driving chronic pain. No miracle is going to make it go away. So the managing pain before it manages you is this big shift that a lot of these patients have to make from the expectation of, I'm going to find the right doctor who's going to perform the correct miracle to get me back pain-free, to this idea of like, whoa, okay, I've got this chronic pain condition. I really want to be able to manage it. I really want better quality of life. What can I do to learn how to manage it, to make it less, to make my life better, to have more quality of life, to be able to do my activities of daily living, that type of thing. So that is the whole CBT program, and ACT in there too, in managing pain. We want to give people a increased sense of control and coping. So as an example, when women go into childbirth, the women that have been, like they've taken childbirth classes or Lamaze or whatever those things are, and they understand what exactly is happening in their body, that the contractions that they feel are really the uterus contracting and pulling apart that cervix. And then when that cervix is about 10 centimeters apart, cervix, there you go, then you're able to push that baby's head out. But women who understand the different stages of labor and delivery and understand what's happening to their body, women who have been given the different types of breathing exercises, women who have some kind of focal point, like I talked about earlier, those women go in there feeling like, it's why they call it prepared childbirth classes. They know what they're getting into to a certain extent. You don't quite know what it's really going to feel like until you get in there. I can speak that from experience. But when people understand what's happening to them and they know that they've got some techniques to be able to control their pain, there's less fear. And less fear and less anxiety in and of itself is going to bring down pain levels. More anxiety, more fear is going to hike up pain levels. So a couple of years ago, I had a hip deformity, a pretty normal hip deformity that you don't really see creating great injury or great pain unless you've got individuals that are more athletic and they have used their movement in their joints more frequently. And so this deformity that I had kind of caught up to me, and I had been having little bit of hip pain for a while, and then eventually I was hiking up a really steep hill, really pulling my legs up and pushing down, and that's when I tore the labrum inside my hip. And then I went for about a year on shots steroid shots before I was able to have arthroscopic surgery, which I had a wonderful, wonderful outcome with that. But I still remember there would be some evenings or some days where the pain in my hip would flare. And when it would flare, it would get increasingly worse throughout the day and the evening. And I would have a hard time standing, a hard time walking, couldn't run anymore. Actually, the only place I felt comfortable was in a bike seat, and there's some mechanics to what was going on with that. I couldn't sit comfortably. I couldn't lay in the bed in any position and be totally comfortable. And it got to the point where on a bad day, I would get really, really scared. Like I can't live with this. I can't move around the way I want to. I'm in pain all the time, sitting, standing, whatever I'm doing. And then at night, it would bother me. So I learned actually when I was away at a conference, that if I could go get ice, a big old thing of ice in the vending machine in the hotel, and then come back to the room and pack my hip in ice, that it would, get really, really cold, but it would stop the flare. Like it would just stop it from that day. And then after that, between that amount of that time when I learned about the ice, and I would oftentimes take a leave, after I learned about the ice, the fear went away. Because it was this kind of thing of like, okay, if I had a bad day, I go home and take on the leave and I pack it on ice, and I know I'm going to be able to calm it down, and I know I'm going to be able to sleep. But it wasn't until I figured out that coping behavior that it started to help me lessen some of the anxiety and lessen some of the fear. But again, even that pain was communicative. That pain was necessary for life, because eventually I had the surgery to correct the tear and the bone deformity that was going on. It was informative because I needed to get that fixed, as an example. So having that control, those coping behaviors, I think a lot about when I'm working with pain patients, as well as when I'm just doing clinical psych with people with stress and psychological stuff. Building a toolbox. We want to help them build a toolbox because for a lot of these individuals, it's going to come out of their self-monitoring. You know, if all you got is a hammer, then the world, you try to make every problem in the world look like it's a nail that needs to be hammered in, when a lot of times you need a wrench, or you need, you know, tubing, or you need glue, whatever, you got it. If you build a toolbox, then individuals then start to learn, okay, if this is going on, I do this. If this is going on, I do this. In the worst case scenario, we've even got chronic pain patients as an example. They might do hot bath, they might do ice, they might do Aleve, they might do meditation, they might do all kinds of things that a lot of times work for them. And if all that stuff doesn't work on a particular day, let's say they fell and they've, you know, re-injured something, then they might take a narcotic to be able to sleep that night. Okay, so big toolbox is important. And building up those, helping them learn what triggers pain, avoid that stuff if they can. And then getting them exercising and getting back functional activity levels. And again, that's where physical therapists are oftentimes, or athletic trainers are going to be involved in their recovery. I know for my hip surgery rehab, it was a very long recovery, but I was very motivated. It had 4 phases in it. The whole first phase, I could not bear weight at all on my hip. So I had crutches, and I would crutch my way around it with no weight bearing, so that the injury inside the hip could heal. But in the meantime, the right side of my body got really, really strong. The left side of my body got really, really weak. So then in phase 2, I started working on how to get strength back, and then I get flexibility back. And then in the later phases, like I could stand, I could walk. Eventually I was able to get to running again. But for the longest time, I couldn't pivot. And I still even remember going up and down the stairs in Smith Wright, or in the halls of Smith Wright, with students around. And I was so afraid that because I couldn't pivot, that I was going to get knocked over in some way. You evil students knocking over professors. But it was like, that was the last kind of thing in the recovery. But a good physical therapist, athletic trainer, is going to be walking that person through a full recovery with that kind of stuff. Okay, cognitively, when we have a preconceived expectation that something is going to be really painful, and they do all these experiments with people who are like, this is going to hurt, or this is going to be terrible, you're going to hate it. And then they actually do some kind of painful stimulus, and they have them rate how bad it was or how not so bad it was. When we expect something to be really, really painful, it is more painful experienced in the brain. So as an example, in prepared childbirth for women, we're expected to call their contractions. The older generations that didn't have this kind of prepared childbirth, I mean, we've been making babies all along, but they would call them when the pains come. And now it's like when the contractions come, because the contractions have function. Again, the contractions keep pulling and pulling, and they're pulling open that cervix. It's got function. It's not just like pain, you're being tortured kind of thing. When we feel like we don't have any control, this is a big issue in healthcare, like in nursing homes, giving people control over being able to decorate their rooms and have their stuff from their home, like their own clothes and their own blankets and that type of stuff. Having a sense of control over one's environment is important. Have you all heard of the machines where you've got somebody and they're on a narcotic anesthesia, and you can either have them up to a pump where they can ask for their own narcotic intermittently when they feel like they need some pain relief, versus if they have to, wait for the pain to build up, call a nurse, have a nurse get there, have the nurse make sure the doctor has written a prescription, and then either give them orally or give them a shot of the medication. Those individuals that have to wait on the nurse and the doctors experience more pain, and actually they use more pain medication. When you give people the device, if you've ever seen anybody who's had one of this, it's not like you can get the device and just like, joy way your way into a nice euphoria, like, woo, man, I'm flying now, because it won't let you allow you to dose yourself unless you've reached a time period. But if you know when you feel like you need it and you can get it right away, those patients actually have less pain and they use less overall medication. So giving them control, as long as, again, they can't overdose, that kind of thing, giving them the control and having them not have to rely on other people to help them out is good. It's a really good thing. If we focus our attention on the pain signal, and this is why distraction is so effective. If you are a shut-in and you are in pain 24/7 and you can't do what you want to do and you've got no social contact, and and all you've got are your thoughts in your head, and all you've got is the focus on what hurts you and you're suffering, boy, that is a formula for more pain. If, on the other hand, you've got distraction, you've got a toolbox, you've got distraction, you've got social support and that connection with other people, you've got things to do, you can use your brain in other ways, use your hands in other ways, then that pain stimulus will be less. If you're anxious and fearful, obviously it's going to be worse. If you're able to calm yourself down and you've got tools in your toolbox, then that is going to help people with their pain. Cognitively, catastrophizing. Catastrophizing, remember, it's when you take one little bad thing and then you think, well, this is going to happen and this is going to get worse and it's going to get a mountain out of a molehill. The most common thoughts, patterns, habitual thoughts that you see in chronic pain patients are, oh my gosh, this is horrible. I can't stand this. This is terrible. I can't live this way. Why do I deserve this? I don't deserve this kind of suffering. Oh, it's getting worse, and it's today and it's tomorrow and it's going to be forevermore. Like, I don't think I can live my life this way if I'm going to be in this kind of pain forever. And then guess where this goes for a lot of chronic pain patients? You got it. Suicidal ideation, and actually suicide rates are higher in chronic pain patients than in people who don't have chronic pain. Makes a lot of sense to me that it is natural for people to catastrophize. Now, what you're going to see at the end of this presentation, JonKabat Zen, he is using mindfulness meditation, because mindfulness meditation is a skill in that toolbox to bring you into the present here and now. So just to even imagine that person who's like, oh my gosh, I can't take this 24/7. It's going to be like this forever. It's killing me. I can't take this. How can I live this way? Oh, maybe I need to kill myself, that type of thing. And his mindful is like, okay, let's just breathe and let's be here in the moment. Is this killing you right now? And then the more you learn to bring back to the present, the more you learn to be mindful, the more that a person learns to relax. Actually, they start to realize they've got many, many moments that they didn't realize they've got lower levels of pain, or even some moments in their life that they've got absolutely no sensation of pain, even though they have chronic pain. And so the catastrophizing is future worrying and making things really, really big. The mindfulness meditation and other strategies and act and cognitive to bring people into the here and now. So the overgeneralizing would be similar kind of thing of like, I do remember when I was going through my hip struggles and I was having a lot of pain with that if I got on the bike, stationary bike or even on a road bike, and I think it's because on a bike seat, your hip is supported by the inside of your pelvis. It's not supported on the outside of your hips. But it was really nice for me to sort of realize, like, okay, sitting uncomfortable, standing uncomfortable, but I could get in a bike seat and actually feel like, oh, I'm okay here, even if I'm just sitting in the seat, or moving in the seat. So I knew it wasn't overgeneralizing to everything. The victimization piece is really interesting. I've worked with quite a few individuals that have been in accidents, natural accidents, or even individuals that have been victimized and harmed by others. And that adds a whole nother layer to chronic pain. So if you've been injured and you've got chronic pain and somebody else did that to you maliciously, oh my goodness, added layer. Or somebody did that to you non-maliciously, ooh, added layer. Or I've even seen people where they did something stupid and they hurt themselves and they've got all this self-blame going on there. That stuff needs to be taken care of and it needs to be treated. I want to tell you about this one client that I got was referred by her physiatrist, which is a pain treatment medical doctor. And then I ended up getting involved with an attorney who really had an agenda she wanted to push. Okay, so here's my client. She was working in an industry that was very hands-on manual labor, all men in the industry. She was the only woman on the site. And there was this one particular man who had been harassing her, coming on to her sexually. She had no, actually she was lesbian, she had no interest in this dude. And she didn't like him, and she tried to avoid him and just kind of keep her space from him. He was just this yucky guy. But it sounds like now, after what happened to her, like he had some issues with a woman doing what he considered to be a man's job. So they're all standing around getting ready to clock out one evening, and out of the corner of her eye, she realizes he's kind of walking up her way, and then she could feel him getting closer to her. And what she thought he was going to do, she thought he was going to reach around with his hands and grope her breast. But what he did instead, let me see if I can illustrate this. He grabbed her arm. So she's standing, he's behind her. He grabbed her arm and jerked it so hard that he pulled her shoulder out of the joint and tore her ligaments and tendons in her shoulder. He assaulted her. And she went down, and people, came over to help her, and they called 911, and she had to go to the hospital. She had to get surgery. And she had tremendous pain going on, and then she's asked to do physical therapy and rehab, but she's traumatized. She's got PTSD over what happened with this guy. And in most interpersonal violence, in fact, more women are injured in the workplace than men are injured by other people in the workplace. You get this double whammy. So her whammy number one was she's been injured. Whammy number two was obviously somebody did this maliciously to her. The owner of the company did not fire this man, and the owner of the company did not press charges. So I mentioned there was an attorney involved. There was an attorney involved who really wanted her to press charges in a civil suit and nail this guy because of the horrible thing that he had done. And she could not process that. She could not figure out what she wanted to do at that point in time. So I get a hold of her and then realized sort of, okay, she's got PTSD. So we had to treat the PTSD first after we built a relationship, and then we do exposure therapies, have her relive the injury and this awful guy over and over again, and bring the PTSD anxiety down to where she no longer had PTSD. Then we could start doing the CBT to treat her chronic pain, and we were able to do that. After we brought the PTSD anxiety down and got her pain down, then she was able to make life decisions. She was able to make a decision about what to do with the attorney, make a decision about she's not going to be able to do manual labor again, how to retrain and find a career in a different field so that she doesn't have to do this physical stuff, and then even making some decisions about relocating and getting away from where this thing happened to her. The self-blame piece is really common. I've seen this in cases with people with chronic pain. I have this one client who got injured in an industrial accident and had police officers and fire fighters come onto the site and tell her and other people what to do. Unfortunately, what they told these people to do put them in more danger. And so she had listened to these authority figures. And I tell you what, in a crisis, if there are authority figures that come on site, most of us would listen to them. We would do what they'd say. We would assume that they know what they were doing. Unfortunately, she was injured more. She inhaled smoke and whatnot and was injured more. And she wishes she will even go to the point of, why did I listen to the police officers, the firefighters? She'll even get to the point in self-blame of, why did I go to work that day? I shouldn't have gone to work that day. I wasn't feeling very well anyways. And I can tell you, like, that's what we do. We get up when we go to work every day. So can you see how deep the self-blame can get sometimes? I think people kind of feel like if I could figure out what I did wrong, maybe there's some way I could have done it differently. I could have undone this bad thing that happened to me. And then obviously people who dwell on pain are going to have more pain. The treatment, this cognitive behavioral therapy, acceptance and commitment therapy is very effective, particularly if you've got psychologists working with medical doctors, working with physical therapists, sometimes occupational therapists, if you have dietitians, lots of different people working together. Much more effective than medical treatment alone. Keep in mind, medical treatment alone, we're oftentimes talking about medications. surgeries, sometimes very successful, sometimes not. Like I know a lot of people have had multiple back surgeries that do not seem to really get at a pure cure. You're going to see a case in the documentary with JonKabat Zinn of Dan. Listen closely to Dan's story. It's tragic. He's had tragedy over tragedy, and back surgeries are not going to fix what he's got going on. They're definitely more effective than placebos. So when we studied this stuff scientifically, ACT and CBT, more effective than placebos. They usually reduce the use of medication. A lot of times when we get in there and we do this stuff, we're trying to get people off narcotics and then maybe onto the NSAIDs and then maybe, you know, using that stuff only as needed, but helping to reduce medications, helping reduce healthcare seeking behavior. Derp's going to come see us, and improve functioning of patients. Hi, Derp, you want to say hi to my class? This is little Derp. She is a daddy's girl. She is not a mommy's girl, but she's got her little spot up here. And so say hi, Derp. Say hi to everybody. Okay, so less healthcare, especially seeking those miracles, improvement of functioning. I'm going to have to put her down here. Okay, there she goes. All right. Epidemiologically, we've got a lot of people who have chronic pain, particularly in the lower back and the neck. And let me explain the evolutionary theory. All right, little girl, I'm going to put you down because I'm going to stand up because I need to show the class something. Okay, I want to talk about evolution of the human spine and vertebrae. So once upon a time, way back in time, before we evolved into bipeds, meaning that we've only got 2 feet that we stand on, we were on all fours. So I want you to imagine some of the, you know, chimpanzees, that kind of thing. We were on all fours, and when we were on all fours, our spinal cord in our vertebrae was flat. So I want you to think about anybody that's any mammal, sorry, that is a quadruped, like little Derp here. She's got a nice straight spine. So think about a horse, or think about a cow, or think about your kitty or your dog. Spine is nice and straight. When we became, across evolution, bipeds, we actually learned we could run a lot faster, which was very functional for survival in being able to catch prey and run away from prey. And one of the things we human beings can do, a lot of the hunters say, like in Africa, have learned this. If you work in coordination with other humans, we're better hunters than if we're working as one. But as bipeds, and you think about human beings who run marathons or ultra marathons, we can run a long time. Whereas a lot of mammals, like think about a cheetah can, you know, run much faster than us, but they are sprinters and they wear out their energy very quickly. So going from all fours, spineless straight, going upright to bipeds, we have now put a curvature on our lower back. Our lower back is now curved in a way that ends up making us very vulnerable to injury in our lower backs. And so most people, when they have back injury, that's what they end up injuring. And then you physical therapists, I know you know this, like we're supposed to do things like if you're picking up something heavy, you're not supposed to lean over and use your back lifting it up. You're supposed to bend and use your legs. Add to that the fact that a lot of individuals in their core is not strong. I learned all about my core in my hip rehab, realizing that everything's got to be nice and strong for everything to work well. And so now I do more of that kind of stuff. If we're not strong in our core, and a lot of people are not, then we overuse that vertebrae and that risks injury. Imagine if you've also got a heavier body, like you've got more body weight, and from a pregnancy standpoint, when we've got extra body weight, we kind of lean back to keep our center of gravity. But even individuals who have larger bellies do a bit of that kind of thing. So lots and lots of vulnerability to the lower back. Now, neck pain. After lower back pain, people in the US end up complaining most about neck pain. And I want, again, take a little comparison between us and other mammals. We have huge heads. We have these well-developed brains, and because of that, we've got much bigger heads than other mammals, and we've got these teeny little tiny necks. And if you add to that the fact there is a surgical procedure that has allowed human heads to pass evolution and allowed human heads to get even bigger. And what is that surgical procedure? We don't inflate our heads. It's not like surgery to make your head bigger. It is C-sections. C-sections. Once upon a time, if you were a woman with a small pelvis who mated with a big man who was big boned and had a big head, I want you to think about that before you choose to mate with somebody and make a baby with them. If they have a big head, you're likely to be carrying a big-headed baby. If you've got a big-headed baby genetically inside of you and you are a woman with a smaller pelvis, in the old days, that mom and that baby would die in labor and delivery because she could not get that head out of there. Nowadays, what they do, they get that baby out of there in that C-section. And so that genetics for that big skull, that big head, has been passed down in the human genome. And so our heads are getting bigger and bigger. Okay, so it's one of these places where C-section has bypassed evolution, and it has actually made our heads bigger, and now more people complain of neck pain and upper back pain because of that. Lots and lots of medical costs because of chronic pain, and lots of work disability and loss of productivity and loss of income because of chronic pain. So lots and lots of consequences from chronic pain. Measurement issues. One of the ways that we measure pain is we ask people to do ratings, and again, those records and those logs, that self-monitoring that we do. What's the quality of the pain? How intense is it on a scale of 1 to 10? Another way that we measure pain are asking people their activities of daily living. Are they able to do everything that they want to be able to do? And the less things that they can do, the more pain they have. It's really challenging to understand pain in pets and pain in children. I've got a horror story of how I tortured my son when he was little. So let me tell you about Forrest and what I did to him. Okay. And being a pediatrician would be my nightmare job, where you've got these kids in your office and they're screaming, they're crying, and their noses are running, and they don't have the words to tell you what's going on. So as a pediatrician, you got to figure it all out. Nightmare job. Okay, so Forrest is little, and he had weaned from me. He had weaned from nursing. I was the dairy queen for quite a while there. He had weaned from me, and we were actually even weaning him from the bottle at that point in time. Point being, whenever he got a bottle instead of a sippy cup, he was very happy to have milk or juice or water in a bottle because he liked that better than a sippy cup. I get up one Sunday morning and I am getting it ready, and I get him dressed, and then I realize, uh-oh, Forrest is sick. But weirdly, whenever he was sick, as soon as he would get sick, especially if he had a fever, he would come and be really clingy to me. He wanted to be held, he wanted to be rocked, he'd want to be touched. And on this particular morning, he's fussy and he's on the floor and he's wringing himself around and he's not clinging to me. And so it's like, wow, Forrest is sick, but this is weird. So I'm like, okay, he's getting sick. So I make him a bottle of milk, and I put Motrin in it, liquid Motrin, and I give him the bottle. And again, he liked his bottle then because we kept giving him these cups that he didn't like. And he gets his bottle, and instead of like, yay, I've got my bottle, he's laying on the floor and he's just flinging it around. He's just like, he's just inconsolable. And I would pick him up and he would just he wouldn't want to like be lovey-dovey like he normally was when he was sick. It was just all like, what's wrong with him? And then I realized, before I get myself dressed and we get up to go to church, whatever, I realized, okay, we're not going anywhere. Forrest is sick. I'm going to undress him, put his jammies back on him. As I undressed him, here's what I realized I had done. I had put his little teeny shoe on, and I had, as his foot went into his shoe, pushed back his middle toe all the way back to, he had an indention on the top of his foot from his toenail. He had been in his shoe with his, this is not funny, this is really sad, I know, mother of the year. He had pushed his toe all the way in, and he had been, no wonder he was hurting. But again, he's flinging around on the floor, he's crying, he's inconsolable, but it's not like he's going, yo, Ma, it's not like he's going, hey, right here, fix this. He didn't know how to communicate that. Same thing happened to my cousin. Her son, when he was a baby, was inconsolable at one point in time. And as she's changing his diaper, and he's just like, she's thinking he's sick too, her hair had gotten wrapped around his toe. and then once she realized she got the hair, it was like cutting off circulation, off the hair off his toe. Then he was fine. Same kind of thing. When I took Forrest's shoe off, he pops down from my lap, and then he just goes running around. He's fine after that. Like he's still got a really funky looking big long middle toe, but He was not injured. He didn't need any kind of medical care for that kind of thing. He just needed a shoe off. So anyways, the lesson learned for me and my cousin was anytime we had an inconsolable baby, strip search, just strip search and see if you can find out what's wrong with them. There are also issues with pain, diagnostic issues and malingering for like court cases when people are faking pain. And there's some really interesting forensic psych where there are ways of assessing pain in people to determine if it is real or if it is fake. Okay, so let's talk about arthritis, which is a common form of pain for a lot of people. Arthritis is inflammation of a joint or damage to a joint that causes pain. 50% of people with arthritis have some kind of disability because of it. About 30% have some disability, 17% have very severe disability, meaning they can't work, they can't take care of their activities of daily living, they have to be cared for by others. A lot of people have functional impairment. 18% have to change their jobs. My example, my client that did the manual labor and then had to retrain and do more desktop labor, desk computer stuff. A lot of people get a slash in their income, and so it's no wonder a lot of chronic pain patients apply for social disability insurance to try to get Medicare to assist Medicare for their health care and to get some disability payments to make a living. And then 60% have a lot of psychological changes. The types of arthritis: osteoarthritis is deterioration of a joint. You see more osteoarthritis asymmetrical, so you could have osteoarthritis, say, in your right knee, but not in your left knee, your right hand, not in your left hand, that kind of thing. You see more of that in people with very large bodies because large bodies put more force on joints. Rheumatoid arthritis is when you get this systemic swelling and pain, but you're getting it in joints all over the body. So systemic meaning everywhere. Rheumatoid arthritis, they can test for in a blood test and look for the driving force. And there's certainly some medications that people can take. But rheumatoid arthritis, particularly if it's not managed, very disabling. Systemic lupus is the most life-threatening of these conditions. Systemic lupus, or just shortened to be lupus. There's one type that is more likely to affect skin and connective tissue, is not as dangerous. So a lot of times individuals get this characteristic butterfly rash. If any of you all remember the singer Seal, he had really kind of disfigured skin on his face, looked like acne scars kind of, but he had systemic lupus. But the most life-threatening lupus is when, from an autoimmune perspective, our own immune system attacks our connective tissue in the body, and that can actually attack organs and kill individuals. Autoimmune conditions are more common in women. More women have lupus than men have lupus. And then the last one, fibromyalgia. 25 years ago, there were a lot of healthcare providers who just believed this was not a thing. This was just depression. This was just people whining, trying to get attention. And now we know fibromyalgia is a very real chronic pain condition. Fibromyalgia is where people have pain in tender points around the joints, but not inside the joints. And if you've ever had an experience of having a high fever and you get that like achy sensation in your body, that's the closest I can help people who are well, who don't have this condition, have some empathy for what fibromyalgia feels like for them. What is interesting is that, and we get in there and we treat sleep a lot when we're treating chronic pain, because if people aren't sleeping well, their pain is going to be worse. And so if we can help them, but then a lot of times they can't sleep because their pain keeps them awake. We can take healthy individuals, and there have been experiments where they've done this in humans, and deprive them of sleep. And what we find is that normal, healthy human beings will start feeling fibromyalgia pain if they are sleep deprived enough. And so again, they're interacting, but we want to get in there and help people manage their pain, help people get better quality sleep, and then we start to make all of those things systemically better. Okay. I would like for you to watch this link. It is a classroom-long documentary. It's featuring Dr. JonKabat Zinn, and it's in the Health and Healing series. And Bill Moyers is the investigative journalist, and so he will be doing the interviewing. I want you to pay attention to, they're going to present a variety of different types of patients in John's group. He is mainly doing mindfulness meditation, but I want you to pay attention to what he's doing in his interventions that really are helping these patients. So he's doing the mindfulness meditation. So he's teaching them how to focus on their breathing, focus on other types of things so they're not focused on their pain. He's teaching them relaxation. He is teaching them other ways of approaching their illness and their pain. He has them doing some really gentle yoga kind of stuff on the yoga mat. So I want you to pay attention to that. In that situation, he's getting people moving who chronic pain patients stop moving. If it hurts to move, you stop moving. It's punishing if you move and it hurts, so you stop moving. Okay, punishment, you decrease behavior. He gets them on the yoga mats and doing some gentle kinds of poses. But for some of the patients, and you're going to see this one in particular, he has such a sweet response. She's crying because she's on the yoga mat and she's moving, but the movement is triggering her pain. And he comes and he comforts her and he helps her realize she can focus on her breath and ride the wave of the pain. And you see her kind of calming down and learning. So at times the movement triggers the pain and gives them an opportunity to practice the breathing and the meditation. In other situations, it just gets people moving again. So I want you to pay attention to that. He's got a really nice way and a good sense of humor in the way that he helps the patients understand their pain and how, and this is very ACTI, acceptance and commitment therapy. If you're always fighting the pain, trying not to feel it, trying not to think about it, but then you're thinking about it all the time and you feel it all the time and you're suffering and you're trying to fight and you're just, that kind of stuff, it's going to be worse. If on the other hand, there is some acceptance, yes, I have chronic pain. Yes, sometimes it's not bad at all. Sometimes it's really bad. I've got this whole toolbox that I have built. So if it comes on, I've got all these different things that I can do to manage it. So just pay attention to that. There's another thing I want you to pay attention to where he's interviewing a gastroenterologist and who makes a lot of referrals to John's group. But the gastroenterologist, the good thing is he recognizes he's got these chronic pain in a lot of his patients, these abdominal, stomach pain, that kind of stuff. And he refers his patients, but he says in the documentary, sometimes I say, I tried it, I couldn't do it. That is not a wise thing to say when you're trying to refer somebody to a treatment that you know that works. And scientifically, there's data that what he is doing in these groups work. Sharing that, I tried it, I couldn't do it. I tried to stop my thoughts. I tried to meditate. Oh, nope, I kept thinking, nope, couldn't do it. We have no idea how motivated he was to learn meditation. I doubt he has chronic pain or HIV or all other kinds of problems that these other patients have. But to say, I tried it, didn't work for me, that's nocebo. And remember, if we've got a treatment that works, we want to add placebo to that treatment. So he would have done better to say to these patients that he's referring, I have seen so many of my patients go to John's group, and for many of them, it totally changes their lives. Placebo on top of getting them to that group. So lots of stuff to watch. I think we could all use more of the mindfulness, Buddhist kind of philosophy training that John does. Again, if you've got any comments or questions, I will develop that forum. But that is the end of part 2 of our pain lecture. I hope everybody is staying healthy out there, and I will see you.